session, which will include some time for our presenters both to discuss ideas amongst themselves if they have reactions to each other's presentations or questions, as well as a final opportunity for individuals from the audience to submit questions and perhaps get multiple perspectives on questions you might have. Our final speaker, Dr. Robert Tressman, is a professor of medicine and psychiatry and executive director of the Correctional Managed Healthcare at University of Connecticut Health Center. He is also the interim co-director of the UConn Center for Public Health and Health Policy, as well as interim division head of the UConn Health Center Division of Public Health and Population Sciences. He received his PhD in psychology and his MD from the University of Tennessee, and he trained in psychiatry at Mount Sinai School of Medicine. He has served as clinical chief of psychiatry at both the Mount Sinai Medical Center and the University of Connecticut Health Center. He has published over 100 articles and book chapters on topics ranging from neurobiology of severe mood and personality disorders to health services research. Please welcome Dr. Tressman.
Good afternoon, everybody. This is okay? Okay. It is a delight to see what has evolved in both NEA-BPD as well as personality disorder research. I got my first grant in the research in the neurobiology of personality disorders back in 1991, and I was one of the very first to get an NIH grant in the field. It's grown dramatically, and the transformation is critical to be able to understand both the disorders, the impact on the people who are at this point in their lives, our patients, as well as the impact on their families. Over the last decade, I've had the opportunity to challenge and the real satisfaction of becoming involved in healthcare for some of the most disadvantaged people in our country, those who become incarcerated. And for the last few years, I've been responsible for oversight of the system of healthcare for those who become incarcerated, and in the state of Connecticut. And one of the challenges clearly is working with people who have misbehaved in one way or another, sometimes profoundly, sometimes very, very minor ways. But from the perspective of someone in healthcare, this is a horrible failure of a social experiment. And the challenge that we face and the opportunity that we have is when people run afoul of the judicial system and the correctional system, can we make this into an opportunity to help them? To receive the health care they might not be able to receive in the community, and to receive the interventions that they might have either shunned, avoided, or not had the opportunity to make use of when they were in the community. I became aware of Dr. Linehan's work back in 1992, when several of us invited her to work with the Department of Mental Health in New York City, and was just both enamored of her work and very, very much supportive of the process. When I became involved in correctional mental health care a little over a decade ago, it became rather obvious to me that DBT was something that might really benefit people who become incarcerated. Certainly, and particularly those with borderline personality disorder, but beyond that, many others. And so what I'd like to do in the talk this afternoon, and I sincerely appreciate your perseverance and sticking around through the whole day, because it's been a fairly intense day, is to talk with you about both my experiences in the process of trying to implement an evidence-based practice, adapting it for use in a correctional setting, and its evolution, both in terms of my own level of understanding and just the pragmatics of healthcare delivery in a very resource-constrained environment, meaning that most people would prefer funding preschool, health care, heating for the disadvantaged in winter, and homeless shelters rather than give money to the correctional system for health care. And I certainly, on the face of it, can't blame our social decision for that, but it comes with consequences. And one of the challenges and consequences is helping to provide adequate care. It's bizarre and strange, but outside the VA system, we run, I believe, New England's largest staff model HMO. It's something I'm very proud of that we are able to do, but as a society, it's rather shameful. That's a topic for another discussion. In this context, I have no conflicts of interest. There are so many people I have to acknowledge and thank for this process. It began a decade ago with a correctional commissioner 4 commissioners ago. And things change because of politics. People come, people go. But each of the participants, both at the executive level of the Department of Correction, as well as the staff at Correctional Managed Healthcare, the staff of the Department of Correction and the facilities have been wonderful supporters and collaborators in this process. And I think you'll see why as I continue. Additionally, the work that began was originally funded through the National Institutes of Justice and subsequently some funding from the NIMH, but the core work was funded through the NIJ, incorporating into this an advisory board that included Andrei Ivanov, very critically, as well as a host of others involved in this process from around the country. And I really have to acknowledge them, as well as you'll see, many individuals recently and currently working with us. As you've already heard, and most of you clearly know, DBT was developed in the 80s by Dr. Linehan, working with traditionally and originally women who were suburban, who were suicidal or self-injurious, who then obviously became clear to her that most carried the diagnosis of borderline PD, driven and so forth. About 6-7 years ago, we published a paper just looking at the different examples around the country of DBT that was being used in either correctional settings or forensic hospitals, like lighting forensic here or others around the nation. And we found that there were, maybe 10, 12 programs that existed around the country to greater or lesser degrees of fidelity to the comprehensive DBT, as well as their ability to be sustainable. In my original role of involvement in correctional managed healthcare, I was director of mental health services. We actually were able to get several of our folks involved in and actually trained in DBT, including Dr. Dan Banish, who is currently director in mental health of the Department of Correction. And we were able to implement DBT programs that were fairly modest in scope in 2 of the facilities. Now, based on that and some work we had done in parallel, it became clear to us that the prevalence, as Dr. Ivanov has already mentioned, of severe personality disorders, as well as many other, particularly Axis 1 disorders, is very, very high in correctional settings. And in a study we had done using research-grade diagnostic assessments of people coming in to Connecticut's jails, we found that the prevalence rate of men coming in meeting criteria for borderline personality disorder was almost 13%, an order of magnitude greater than in the community, as well as about 23% of all women coming in, 1 out of every 4. So dramatic elevations in people who meet research-level criteria for borderline personality disorder. It was also clear that there were real opportunities. And these are similar to what Andre had recently said. We're trying to help people function more effectively, reducing the symptom burden, reducing self-mutilatory or aggressive behaviors, increasing prosocial behaviors, and really changing maladaptive thinking. There was a comment before about, are we trying to make prisons or jails into less punitive places? The Department of Correction in Connecticut houses approximately 17,500 people at any given time. They're integrated jails and prisons, meaning people pre-sentencing or just sentenced for a short period of time for a misdemeanor, or longer times in prisons for a felony conviction. The whole system, well over 30,000 people a year come back to our communities. So we're not just treating people while they're incarcerated. Please think of correctional health care as a public health intervention to try to not only help those individuals, but the families and the communities to whom they return. Because 98% of people incarcerated go back to our communities. We were focusing on DBT as it was originally created and looking at targeting very specific inmate behaviors of disorderly conduct and insulting language, threats, self-mutilation, suicidality, and so forth. And the real goal that we were focusing on was helping people to acquire the emotional, cognitive, and behavioral skills that would improve their problem-solving ability in their prosocial interactions. There are real challenges to this, in case it hasn't become clear yet. First, and by no means trivially, is the comorbidity. The comorbidity on Axis 1 and Axis 2, primary mental health disorders, is profound, with anxiety, stress disorders, and psychotic disorders. Many also have co-occurring Axis 2 disorders, whether it's antisocial personality disorder, paranoid personality disorder, or others. The substance abuse is pandemic. In every study done, between 60 and 90% of those with diagnosable mental illness in a correctional setting also have co-occurring substance misuse problems. So when you take that into account, along with the fact that I did write in here, in every study done around the country, between 30 and 75% of people have traumatic brain injury who are incarcerated. The stuff of impulsivity lends itself to people getting into arguments, fights, getting knocked over the head, getting knocked unconscious. The neurotoxins that they are absorbing through the substance abuse, all of these things, not to mention the pervasive distress that they've experienced, contributes to the issue of, there are virtually no people with a single diagnostic entity in the Department of Correction. So it's important to think much more about dimensions of dysfunction than pure diagnoses. Because it's important to share that with you, because this is, in general, a population that has been abused and has abused their bodies as well. Challenges in correctional settings. This is a safety-first environment. We are guests in the house of a Department of Correction as we provide health care. Safety trumps everything. And so everything must be done in that fashion. There are many, many issues. A dual allegiance. In the community, a therapist, a psychiatrist, has only the responsibility to the patient, with certain very limited exceptions. In a correctional setting, there's dual allegiance. We are obligated to let the security staff know if there are issues that would compromise safety and security. So there are a whole range of things that complicate life. Additionally, you'd think that when you incarcerated someone, they'd stay put. They don't. They are moved from one part of the building to another, and they're not going to know it, but because of safety reasons. If the Department of Correction feels it's important for one reason or another to move them from one facility in one city to another, the next day they're gone. So there are all of these issues and challenges when caring for people, let alone doing a randomized clinical trial. The benefit to people participating are really to help to reduce life-threatening behaviors, to reduce treatment-interfering behaviors, and to help target quality of life interfering behaviors. No different in the community than in correctional settings. But the goal here is also using highly structured content and format and to help to engage people who may be treatment resistant. Organizing a research study in the Department of Correction is like moving an army. You've got to get many people engaged and everybody to support it, otherwise it will not happen. And so this is not an unusual kind of table of organization to do a research study. When we were doing this, one of our challenges, and we originally got all of our research associates trained by Dr. Linehan's team to do DBT, and we were trying to adapt it appropriately to the correctional setting. We were looking to structure our intervention in this research study to be able to have standardized battery of assessments. And similarly, as Dr. Ivanov had mentioned, we would do it initially, and then at week 17, immediately after the DBT classes ended, then 6 months later, and at 12 months. We would gather the information around it. We used the original DBT as a basis. We reworked the manual and the worksheets with national input from our advisory board. And we also developed training not only for our clinician researchers, but for the staff, so that the staff would not inadvertently undermine it. Because staff in a correctional facility is a lot like on an inpatient unit. There are 3 shifts, they're there all the time, and anybody who works in an inpatient unit on first shift who doesn't communicate effectively with second and third shift is doomed to failure. So we really need to coordinate, and did. We've trained over 100 correctional officers in understanding what DBT is about and what to anticipate with people who are participating in this. We developed a 16-week corrections modified version of DBT with 2 sessions per week for 1 hour each session. Because there are several issues. We focused to try to understand the process, to see what mattered most. We structured it to separate out some of the components of comprehensive DBT. We had the skills training sessions up front, and we examined that. We then randomized everyone who participated into either just simple case management or reinforcement of DBT skills, the way you would one-on-one, for a period of 8 weeks following the end of the skills training program. And so the goal was both to see first if the skills training alone would be of some benefit, and would we see any difference between the 2 groups in follow-up, between the one-on-one session and just case management. Keeping in mind, this is dramatically different as an environment than the community. This is congregate living with razor wire. People are there working with a consistent team of people day in and day out who can help to reinforce their behaviors anyway. So there is that. And they are told when to wake up, they are told when to eat, they are told where to go. It's a very infantilizing environment and highly rigid. So a lot of the expectations and demand characteristics that we would expect in the community really are turned on their heads, along with the fact that people on average have a 5th grade reading level in a correctional setting and have had trauma, brain trauma and a whole range of other things. So with that, what do we find? Cutting to the chase. We found that when we look at problematic behavior that really rises to a level that DOC gets involved, a disciplinary report or a TIC, and they, disobeying a direct order, not being where you're supposed to be, fighting, things like this. On average, the average number of tickets per month per person that the individuals who participated in this group got beforehand were 12 tickets per month. That's like sitting in the principal's office all the time with no windows to look out of. During the intervention, it dropped dramatically. And then follow-up over the next 6 months, it returned somewhat, but there was persistent improvement in behavior. And this was a kind of a classic example. Obviously, detailed change, but Mr. Brown diagnosed, primary diagnosis, not the only one, borderline personality disorder. Very high profile, numerous problematic behaviors, highly suspicious, with lots of inappropriate outbursts that would get him into trouble with lots of folks. He often refused his medication, complained of physical ailments, muscle stiffness, and fatigue. After participating in this study, he literally didn't get any for the full year of disciplinary infractions. His vulnerability dramatically dropped. He was eating regularly, exercising regularly, he took his medications consistently. He articulated that reducing his vulnerability was key to reducing his susceptibility to negative emotions. Using the classic behavior chain analysis, he was able to problem solve alternative behaviors. So it was really quite good. And we've shared some of these results and published these pilot data. In the one study with women and men, we found a significant reduction in the targeted behavior from baseline to the end of the groups, and both the case management, that one randomized arm, and the coaching were significant, but not different from each other at the 12-month follow-up, supporting the potential value of DBT as this modification demonstrated. It was not comprehensive DBT, but nevertheless significantly improved the target issues and behaviors in prison settings. We also looked specifically at a separate adolescent population. And what we found in these 38 adolescent boys, there were significant changes, statistically significant, in physical aggression, in using distancing coping methods, and the number of disciplinary reports that they got. And so we were able to demonstrate in this very difficult to manage population that even a very reduced skills-based intervention that was not comprehensive DBT had benefit in the correctional setting. The challenge is multifold. In a correctional setting, there is a lot of turnover, obviously of our inmates, but also staff. It's a difficult environment in which to work. It costs a lot to train people in DBT. And when there's key staff that turn over, and some of my own research staff turned over in the period of time doing this, it's expensive and challenging to maintain an adequate level of adequately trained staff in a resource-challenged correctional environment. The other thing was that we found we got a lot of negative feedback about all of the DBT jargon and all the specialized language that was used. It was hard for a lot of our folks to remember it. There were also the costs of the training and the use of the materials and a lot of the issues with copyright. Based on our experience, working with the same initial group of national advisors, we started building something we ended up calling Start Now. It's an integrative skills training model informed by a whole range of interventions, including DBT, targeting the population who are emotionally unstable, impulsive, frequently impulsively aggressive, who have problems with interpersonal dynamics and perceptual distortion, and difficulty with self-regulation. So what we ended up doing with this, when we started thinking about it, how did we design it? We developed 32 skills training group sessions that were each 75 minutes in length, as long as we could get away with in a correctional environment because of all of the challenges with scheduling and corrections. We, wherever possible, structured it to be co-facilitated, but it does not need to be. There's the potential for rolling admissions in between there are 4 units, and people could come in on any one of the 4 units so that it might be usable in one of our jail environments where people don't stay too long, on average about 30 days. And we developed the participant workbook, Facilitator Manual, and checklists that we would use and implement for fidelity monitoring and supervision. And as we were looking at this, we were trying to develop something that would be appropriate for implementation with masters prepared clinicians and could be shared in a cost-affordable manner with many people so that it could be performed in as many as 16 different facilities across a state. And that's the small state of Connecticut. So having a cadre trained that was affordable was really key. So to do so, we developed a facilitator manual that was highly structured, highly scripted, and very detailed, with lots of basic scripts and examples provided to the clinicians so that they would be able to draw upon this as opposed to many years of sophisticated experience that they may already have had or not. We developed workbooks that were gender specific and were written at a 4th to 5th grade reading level. What did we do in this? We included key cognitive behavioral interventions. Behavior is simply understood in the context of its antecedents and anticipated consequences, and using functional analysis. And looking for triggers and interpreting events or triggers as a component of it. The emphasis is clearly on learning and practicing new coping skills during and between sessions. Some of the classic components of any cognitive behavioral intervention. So during the group, we use role play and brainstorming and problem solving and shaping of desired behaviors. And we use a very, very simple, as you'll see, antecedent behavior consequence form for the functional analysis. These are generally folks who have failed at many, many things in their lives. Who here really likes to do their functional analysis and looks forward to it? The challenge for us is to find ways to engage people at a level where it's not too painful to relive these experiences and craft alternative endpoints that would be beneficial to them. And homework. Virtually everyone who we treat failed school. We don't want to give them more homework, so we actually just redefined it, renamed it, so that it's real-life practice exercises. It's pure semantics. Call it what you will, but it doesn't get the emotional reaction, the negative emotional reaction that the word homework gets from so many of our folks. We incorporated into the core of this the structure of motivational interviewing to express empathy and acceptance, to develop a sense of discrepancy, as well as rolling with the resistance of the patient, the person who's working with us. And to support self-efficacy. There's an emphasis on accepting the ambivalence that's going to be there and to go with that, to support self-efficacy through focusing on strengths, and to elicit change talk and to work through the ambivalence. It's built into this. Offender focus on this. We've written it so that it's designed for use in correctional settings, using correctional examples and appropriate coping behaviors relevant to these settings. The concepts and language are dramatically simplified, given many of the issues with traumatic brain injury and so many other insults and academic limitations that many of our folks have had. It's very visual. It's very iconic in the participant workbooks. So the visual, the iconic, is also a useful trigger to help people remember things who may be verbally limited or suffer with traumatic brain injury. The Facilitator Manual includes lots of examples and tips for engaging difficult to engage folks. So a lot of that feeds right into the issue of neurocognitive rehabilitation. Dr. Diana or Denny Fishbein from the Research Triangle Institute was a key participant in helping us develop START Now. She started out with a research career at NIDA, but really is a neuropsychologist who really focuses on a lot of the issues of neurocognitive impairment. So we really focused on specific dimensions of executive control. We would have liked to have used more mindfulness techniques, but they're too sophisticated for many folks. We used just core focusing skills, and now about 30 different simple, easy-to-use things for focusing opportunities for folks. For the cognitive, self-regulatory, and monitoring strategies we're trying to use to help people assess consequences and inhibit impulses. As you have heard repeatedly today, trying to help people expand the time frame before they are triggered so that they don't act and then think, but rather find a way to help them think before they act. And we're trying to use real-world examples because a lot of the stuff that exists in a lot of interventions will not generalize. And so we try to use things that will be of direct relevance to that person in that setting without anticipating that they're going to have the sophistication to generalize what they've learned. DBT, clearly, it was really on the basis of our research and experience with mindfulness that helped us to choose the focusing skills. Emphasis on acceptance, coming from the dialectics, is really critical to this, and in conjunction with the motivational interviewing is really core to what we try to do. Gender-specific interventions can be critical, particularly the women in corrections and the needs that they have. 67, 68% by most studies have lifetime history of post-traumatic stress disorder. There are so many other things that really require gender-specific awareness. So we've written the workbooks to be gender-specific and to give the facilitators the different examples as well. Women obviously have very different, more profound affiliative needs, even while incarcerated, than do most men, as opposed to a lot of the pressures that men experience to appear machismo. I already mentioned the trauma-sensitive care issues, and we really work to try to be sensitive to the stressful situations that may have triggered what once was the best they could do to cope with trauma in their lives that may no longer be beneficial for them. There's a real issue on grounding skills and self-monitoring. And so with this, the typical session, there'll be welcoming new members. We tend to review the real-life practice exercises from any previous session. It takes 10 to 15 minutes. We usually have between, at most 10 people in a group, usually 6 to 8. We provide opportunity to share responses, offer and listen to feedback. Then, for 10 to 15 minutes, practice focusing or ABC skills and alternate that. And then develop time for the introduction of a new skill, using a Socratic kind of approach, asking questions to get people thinking, then link the skills to situations, trying to build on motivation, find a balance between enthusiasm for the new topic and rolling with the resistance that frequently comes up. The next is the actual in-session practice of this new skill, role-playing, brainstorming, whatever it will be, as part of the introduction to it. Getting people to be active and participating, making notes or sketching in books is encouraged, but optional in this. There's a whiteboard in each of the rooms that we use at that time and so forth. We assign new real-life practice exercises. And it's like this, in the first unit, My Foundation, starting with me, it focuses on developing increased self-control and ability to cope with stressors. Includes setting a treatment goal, increasing wellness skills, accepting oneself and situation, enhancing spirituality, values, and personal boundaries. That's unit 1. Unit 2, emotions, my emotions, dealing with my upset feelings. For so many of our patients, our clients, our consumers, it's funny how in my position, I wear all 3 hats, which is most peculiar. But the people who are in our care, helping them at this point to focus on recognizing and understanding their emotions, which is a huge issue, and then coping with those emotions through actions, through thoughts or imagery, and coping with depression, anger, anxiety, and so, my emotions. This would be one of the sessions within that unit. Some people see their emotions as an invading force. They try to get away from their emotions or just put up with them. A lot of the cartoons seem kind of silly, but it's visually powerful, easy to remember, and it's something that can help people get engaged. We've recently, by the way, translated all of this into Spanish to really help with many people. The majority of people who become incarcerated, by the way, at least in Connecticut, are bilingual. Very few are monolingual Spanish, but many, many people have a hard time reading in English. And so the Spanish option, I think, is going to be really of enormous value for us. In the 14th session, also, is focusing on coping with upset feelings through thoughts and imagery. So In practice, people would reinforce the idea that how we process things affects our emotional reaction. To think about thought errors, all or nothing thinking, mind reading, negative self-talk, all the basics. And then going through examples and descriptions and helping make them more concrete. I mentioned the ABC functional analysis. This is what we use. This is literally the kind of sheet of paper that people would use. And this is just an example that has been previously filled out. So what triggered me? What was going on? I was at Chow eating. A paper with writing on it was passed to me. The correctional officer took it and wrote me up for a ticket. What was going on inside of me? What were the activators? I wanted to know what that note said. I was angry that I got written up for it, and I felt like cursing out the correctional officer. Never a good idea, by the way. What did I do? I punched the wall when I got back to my cell. What were the consequences? What were the positive consequences of punching the wall? Well, I didn't tell off the CO, and I didn't get a worse ticket. The negative consequences, my hand was bleeding. What are the alternatives? What can I do? Well, I can realistically appeal the ticket. It's a judicial process, even while incarcerated. What are the consequences? Well, I wouldn't end up with a sore hand, and I might not be put into a disciplinary area. But the negative is I probably won't win the appeal, but I will have gone through the process. I will have at least empowered myself by using an opportunity and a tool. So we use very, very concrete correction-specific situation. Our third major unit, 4, my relationships. So from the first focusing to my emotions to my relationships with others. Developing positive relationship skills. Again, core things. Listen, assertiveness, setting boundaries, asking for support, avoiding destructive relationships, and coping with rejection. The 4th unit is the final one, focusing on the future, setting and meeting goals. It's not enough just to have these tools. It's also critical to think about, well, where am I going? Because if I have an investment in the future, I'm far more likely to be willing to put up with frustration in the present. So it develops hope. It's intended to set realistic goals and help to break them down into achievable steps, learn problem-solving skills to achieve those, and to learn to set and meet educational and vocational goals. Now, because of 30,000 people turning over, it's unusual that we don't have an electronic health record. And if OPM is here, if you could give me an electronic health record, please, it would make life wonderful. But in the absence of that, we do have diagnoses in the chart. We're gathering it for this. And the data I'm going to share with you are quality assurance data. This is only the results of implementing an evidence-informed treatment into a statewide correctional system as a standard of care that we're trying to develop. It's been a fascinating process. And for any of those in the audience, just if you're a principal investigator, always being frustrated that, well, you've developed this great thing, but you can't get it out there and disseminate it. Well, in my process here, I've gone from being just the principal investigator to being the omniscient, omnipotent executive director of correctional managed healthcare. I got 800 employees who report to me. You think I can get this stuff done? It's really hard to implement a practice that changes the way our clinicians behave. It's not just changing the behavior of our patients. Changing any person's behavior is difficult. And so it's been a process over the last few years of using the Dean Fixon model of implementation of evidence-informed and evidence-based practice into a community-based environment. And we've been building a quality assurance, quality improvement model. So we've been working to do this. So that's the background. And Dr. Susan Sample, who's the primary author of START Now, has been intimately involved in this process. Dr. Walter Krause has been great. There have been many, many people who participated in this. In our education and training area, Amy Hood has been fabulous at helping to do a lot of the trainings. There have been countless people who participated in this process. In that context, going forward, there are about half of the people who participated in START Now by the rough clinical estimates of our clinicians, have estimated meet criteria for borderline PD, and very likely meet lots of other diagnoses and are likely on one or more medications. So the comorbidity is extraordinarily high. And the challenges for us are really fascinating in teasing all this stuff apart. So we've been able to publish one process evaluation looking at inmates, particularly the group initially with impulsive and aggressive behaviors. What we have now, at this time, 9 of our facilities have active Start Now programs statewide in Connecticut. And there are about a half dozen other states, by the way, at different levels of looking to implement a small program in Sweden that's using it. It's an interesting kind of a dynamic in this process. Right now, we have about 44 clinicians currently trained and who continue to be accredited. You have to do a group once a year at a minimum to maintain the certification to be a Start Now clinician. There are about 150 people, give or take, who are in active treatment right now. On the results of this quality assurance data, we have a patient participant satisfaction data that we collect. There are 380 individuals who have given us this feedback so far. So on this question number 3, to what extent has Start Now met your needs? So overall, it's on a 3 of 4 base, or on a 4 meaning almost everything has been done. Best thing since sliced bread versus a 1, which is nothing. The majority of people for most of the units, 3 to 4. If a friend were in need of similar help, would you recommend that he or she participate in Start Now? And again, between 3 and 4, now averaging more close to 3.5. Has Start Now helped you to deal more effectively with your problems? Same criteria, and in general, from 3 to 4. Interestingly, Unit 1 tends to score the lowest, and that's just the core focusing skills, as you may recall, as opposed to focusing on emotions, interpersonal skills, or the future. But still, 3 out of 4, I'll take it. And another question. Has participation in Start Now helped you cope with daily life in prison or jail? Again, same kinds of scores, between 3 and 4 consistently. If you were to seek help again, would you participate in the Start Now unit? Again, between 3 and 4, averaging closer to 3.5. Many people, by the way, after they complete it, ask if they can come back again. Like anything, in DBT or any cognitive intervention, it requires practice. And the more people do it, the more they absorb. So it's a really great thing to see that it is a very positive experience. Now, that's self-report and participant satisfaction. This is, again, quality assurance, preliminary data, just looking at 2 variables. The first one is how many days are people spending in the correctional equivalent of an inpatient hospital. We're using rough numbers, by the way, just to give you a context. On any given day of our 17,500 people, approximately 3,500 of them are in active mental health treatment. We have approximately 20 psychiatrists, 20 PsyD or PhD psychologists, about 90 social workers, either master's prepared and or licensure candidates, the vast majority are licensed, who, along with 450 nurses throughout the system, in delivering this care and participating in it. We have multiple settings where there are infirmaries, which are our equivalent to inpatient hospital units where we deliver care. So obviously we're trying to reduce the number of inpatient hospital days, and that's one reflection of improved functioning. With 126 people in this sample, the 3-month period prior to beginning Start Now, they averaged about 0.6 days per person in the hospital, okay? While they're participating over the Start Now period, about 4 months, that was cut down to less than, or about a quarter of 1 day. And During the 3 months after the completion of treatment, it dropped even further. So that was really delightful and remarkable. This is really very new, and it's only quality assurance. This is not any kind of controlled data. Similarly, how many disciplinary reports or tickets did people get? They were getting about 0.2, 0.18 on average, for each of the 126 people for the 3-month period prior. During Start Now, it didn't change, but it actually dropped as they started using their skill set afterwards, down to about 0.1. So this is really promising. Something that's even more promising in some ways, in a much more controlled evaluation study. We've collaborated, Dr. Susan Sample and I and others, with the Department of Mental Health and Addiction Services in one of their alternative to incarceration programs for people with dual diagnosis, severely mentally ill and substance abusing. And in that program, they have used and have been using Start Now. That was mildly adapted for use with that population. Of all of the variables that they studied and looked at, community retention, meaning how long did they stay in the community until they were either violated on parole or probation or were incarcerated for a new offense. The only thing that seemed to be a significant variable to keep people in the community longer was Start Now. And the really cool thing from my perspective was that it really was a dose response. The more sessions they were in, the longer they stayed in the community. And it's not the inverse. It's not simply because they were in the community longer, they were able to participate. The timing was such to be able to demonstrate that. This was a study primarily, or chaired, or headed by Linda Frisman, who was the most recent Director of Research for DMS. So, what do we got? We are finally at a point where there are a small cadre of people really interested in treating people with severe problems of emotion regulation and impulsivity, many of whom who are diagnosed with borderline personality disorder, who become incarcerated, who are and people are interested in helping to empower them to develop the tools needed to get out and to stay in the community. There are evolving tools that we can use, and ultimately we may be able to look at understanding what are the differential characteristics of our people which should guide the selection of treatments. Who might do better in one versus the other? Not only driven by the financial impact and cost, but also on the characteristics of who will likely respond. As you've heard earlier, in terms of some of the beginning notions of either genomic or individual characteristics of who might respond to which kinds of treatment. But these preliminary results for both of these studies suggest to me that these kinds of interventions have enormous value. And if I had my druthers, I'd go ahead and just incorporate them into the curriculum of 5th graders everywhere, so that they would have the tools they need as they enter adolescence. Forget this, treating them after they're sick. So, barring that, I don't quite have that authority, at least now we can begin to do more formal, controlled studies to be able to evaluate for whom which studies work best, which interventions work best, and what combinations of psychotherapy and psychopharmacology help to support and optimize the function of the individuals in our care. I really want to thank you guys. You've been phenomenal, not just for what's going on here, but for the fact that you came and for your interest and your daily investment in this population. Thanks.
We have a number of questions that have come in, and please take advantage of sending more. Specific questions. Are there any exclusionary criteria involved with research exemption?
I'm sorry, with
the Start Now. Let's focus it on the Start Now. Were there exclusionary criteria in terms of who would participate?
Yeah, it's pragmatic, but it's interesting. Yes, if someone is in If they're in the mental health infirmary or grossly medically impaired and are unable to participate, that's an exclusion. If they choose not to participate, it's not mandatory. Those are the biggest ones. In our maximum security facilities with people who are not allowed to be in groups, we actually are doing this one-on-one. We try to adapt it so the skills training can be done one-on-one with individuals. So we're trying to come up with strategies to optimize it and minimize the limitations.
And another specific question, are there any statistical differences between minimum and maximum security units in these cells?
In what we have seen, no. I was looking at that. So no, it does not seem to be relevant. And the maximum security would tend to be those who are either at greater risk of physical violence or one of a host of other reasons. So there are a lot of people who, in terms of their mental illness or their emotion dysregulation, impulsivity, might indeed be at a minimum security or maximum.
We have a few questions about the training of corrections officers, whether they provided coaching, which I believe might be the DBT, or whether they've been involved with the other, with the Start Now.
In terms of the coaching, they knew some of the words. And one of the wonderful examples I recall from the study was one of the correctional officers who was not, in general, what would be considered a warm and fuzzy individual. When someone who he knew on his unit was participating in the DBT the corrections modified program, saw him starting to act out, starting to lose it, actually said to him, "Remember your mindfulness skills." So anything is possible. That just brightened my day. And so yes, they were taught enough to get a basic understanding, but not much at all. I mean, it was really just a 3-hour introduction to it. It was not in any way real extensive training. And for Start Now, yes, many of the counselors, supervisors who are correctional staff have actually been trained in Start Now, so that they, even if they don't use it, they are aware of it and can support the process.
Does the Start Now involve any efforts to manage the milieu, the more broad milieu? It relates a little bit, but
realistically, no. What we have done, Start Now doesn't, but our own clinicians do. And as they demonstrate, and particularly hiding in the back here, Drs. Berger and Chaplin, who run the mental health program in corrections, have demonstrated over the years, the more that our staff demonstrates their ability to work collaboratively, both with the people who at this point in their lives are inmates and with the correctional staff, that allows greater room for flexibility on that unit. And so to the degree to which the intervention reduces any safety risk, allows greater flexibility on the unit.
Okay, have these interventions been used with deaf or hard of hearing?
What was that? It's the end of the day, it's Friday. Sorry, my apologies. No, unfortunately. And for hard of hearing individuals, we engage them, but we don't have, that's an interesting thing. And Bob or Paul, are you aware that we use any sign translators at any of our facilities for Start Now? No, it's a wonderful question, and it's actually something we might want to pursue.
There's a question about offering these sorts of services in a justice system. The question is, being a clinician in the juvenile justice system in Connecticut, I hear a lot of controversy about doing motivational interviewing in detention with juveniles. One, because you don't have parental consent, and two, because detention is not a mental health facility. What are your thoughts on these controversial issues?
Well, juvenile detention, all the members of my staff, headed by Kathy Coleman, do the quality assurance work for all of the juvenile detention programs in Connecticut, and work with detention to really support great improvement. specifically with those interventions, if the average time the kids are in a detention unit is typically 2 to 3 weeks. There are outliers, but 2 or 3 weeks. They're there. Some of them shouldn't be there, but they are because of judicial issues. If they're there, at least in my opinion, we do, and we hire some of the staff from this institution to provide care. You know, the Court Support Services hires Yale, among other clinicians, to provide the care in the detention centers. And so it is community clinicians providing the care. And anything that can use an opportunity to enhance the engagement of kids so that they don't get involved in the adult system has my blessing. I'm very biased that way. I'd much rather be sued for intervening inappropriately than not taking an opportunity to try to do some good. I'm pretty basic that way.
With the efforts to train staff, including corrections officers perhaps, there's a question about strategies for getting past any resistance to learning these sorts of approaches, and then also efforts to assess whether they are actually understanding the skills, that they're understanding validation or coaching or those sorts of things. So one is about kind of getting commitment of people in the settings, perhaps also correction officers, and assessment, did they actually learn it?
Right. For our staff who go through the training, we also have an integrated system of supervision. And so there is supervision. They are actually expected to be able to demonstrate what they do and how they're doing it and review it so that we do, and it's evolving. But we've integrated this structured supervision into the system. Over time, I do hope we'll be able to build upon that to be able to do videotaping, to be able to demonstrate that. Right now, all we can do is occasionally have the supervisor go in and watch.
Can you say again, can you review the data on the recidivism and then also comment on whether the Start Now is being proposed as a cost-saving program based on that data?
The data suggested, and this is as yet unpublished, Dr. Friskman is working on that data set. This is an internal DEMAS document that I believe, if you ask, you probably get it through Dr. Linda Friskman or Dr. Ezra Griffith, who's medical director. But it demonstrated, using all the appropriate, using a Cox regression model, demonstrating increased survival in the community, not survival until death, but before reincarceration. And with a session-specific model, each session increased the chances of them staying in the community longer by about 2%. And in terms of a cost-saving initiative, we are working on submissions to get funding to do a formal randomized clinical trial, which would ultimately be necessary before we could actually go to that step.
We have several people asking about the availability of the Start Now materials, the workbooks, the manuals.
Through our website, all you need to do is cmhc.uchc.edu. cmhc.uchc.edu. On that website, under mental health programming, Start Now. And there's a tiny form to fill out. I'm interested in Start Now. Can you share with me your materials? We had this all vetted to make sure we weren't stepping on anybody's toes. It's in the public domain. It's free intellectual property that we're delighted to share. So we're happy to share it with people.
Could you repeat that?
Sure. cmhc.uchc.edu.
Thank you, Dr. Tressman.